Welcome to PFT Tutor with Jeffrey Haynes. In this video, we're going to briefly discuss whether or not caffeine needs to be held prior to a pulmonary function test. In many laboratories, patient instructions includes withholding caffeine on the day of testing. That's probably not going to be very popular with most of your patients, especially if they're scheduled later in the day. The rationale for withholding caffeine before PFTs is that it is a member of the methylxanthine class of drugs that can have a bronchodilator effect, albeit a weak one. Another methylxanthine drug is theophylline, which used to be a popular medication for asthma and COPD, but isn't really used much anymore. So is this potential bronchodilator effect really something that we should be concerned about? This is a small study that was published a few years ago in 16 asthmatic patients. They randomized the patients to a single-blind crossover trial of 16 ounces of caffeinated coffee and 16 ounces of decaffeinated coffee consumed on separate days. They measured the fraction of exhaled nitric oxide and FEV1 before and 1 hour after consuming coffee, and they performed a methacholine challenge 1 hour after coffee. And here are the results. So after consuming decaffeinated coffee, there was no difference in FEV1. There was a statistically significant difference in the FeNO, the fraction of exhaled nitric oxide. However, this is not clinically important. That would not affect decision making. You can also see that there is caffeine in decaffeinated coffee, and they got a PC20 from a methacholine challenge of 1.36. After drinking caffeinated coffee, once again, there was no difference in FEV1. There was no difference in FeNO, and the PC20 from the methacholine was exactly the same. So caffeine doesn't seem to have much an effect on bronchodilator responsiveness. But even if it did, does it really matter? We spend a lot of time and energy measuring bronchodilator responsiveness because important associations have been linked to it, including the ability to distinguish between COPD and asthma. This turns out to be all wrong. A fair amount of patients with COPD will show bronchodilator responsiveness, and a similar amount of patients with asthma will not. This study shows the ability of a change in FEV1 or FVC greater than 10% of the predicted, the current criteria for determining bronchodilator responsiveness, to distinguish between asthma and COPD. Over here shows the score of the area under the curve, which helps to grade whether or not a test is good at distinguishing between a diagnosis. So, a perfect test, like a pregnancy test, would be 0.99 or 1.0. The ability of bronchodilator responsiveness to distinguish between asthma and COPD scored out at 0.5, which is basically no better than a coin flip. So all the data seems to show that there's no reason to withhold caffeine before standard pulmonary function tests or methacholine challenges. All you're going to get is grumpy patients. And there are some patients who develop headaches when they don't consume their usual amounts of caffeine, and patients with headaches generally don't like to perform spirometry. There is one circumstance in which it may be important to withhold caffeine, and that is if you're doing an indirect bronchoprovocation test. I mentioned that it's not necessary to withhold caffeine before a methacholine challenge test, but a methacholine challenge test is a direct bronchoprovocation test. So it acts directly on the airway smooth muscle, just like a bronchodilator like albuterol would. Indirect bronchoprovocation tests have to increase the osmolarity of the airway surface liquid, which eventually will lead to mediator release from cellular inflammation, and then that acts on the airway smooth muscle. Examples of indirect bronchoprovocation tests include mannitol, exercise challenge, eucapnic voluntary hyperventilation, and cold air, which can be done also with exercise and eucapnic voluntary hyperventilation. For these tests, the European Respiratory Society standards for indirect bronchoprovocation challenges recommend that caffeine be withheld for 24 hours. And there is some data to support this. This is an older study of patients undergoing an exercise challenge test. This is the 2 hours prior to the exercise challenge, and this is where the exercise takes place. So these two lines here are the baseline values and placebo. So they did the exercise challenge, and you see the drop in the FEV1. And these lines up here, especially the top one, is the higher level of caffeine. And as you can see, high doses of caffeine does reduce the response of FEV1 to exercise. So patients should not consume caffeine before an indirect bronchial challenge test, but for routine testing, there's no reason to withhold caffeine, and you'll have the benefit of happier patients. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.